description and maybe the follow-up for next steps. Other data sources for artificial intelligence testing, and we're going to speak at the end about synthetic data and a few examples that we have some research project ongoing at the Institute, and I want to speak about that too. So data policy and procedures, this is a very complex topic. The hospital, I'm going to speak only for the MUHC now, have policies, have procedures, but unfortunately we don't have any specific policy and specific procedure to speak about how to access data and describe all the process at the MUHC. So that's a lack, if you want, that we recognize. And also we have, if you want, the main policy that we have at the hospital is 2019, Governance des Actifs Informaticiens. It's a document, I think it's only in French, and maybe it's a little bit, it's not actualized. And this document speaks more about the relationship between different committees and how the committees provide and approve access to data and all the governance of the data. So more than 1 year ago, we decided to start to work in a data governance framework. Basically, the MUHC and the Research Institute work in collaboration with the CGP, that is a McGill group working in also genetic and policies, to develop a data governance framework to outline the legal and ethical obligation on the collection, use, and disclosure of clinical and administrative data for research within and outside the MUHC and the Research Institute. So basically, this is the main objective of this document, to have an umbrella of all the data sharing between the MUHC and the Research Institute. This framework seeks to outline and comply with Quebec privacy legislation. Basically, is more attached to Law 5. And the framework is limited to, in scope to public or private institution in Quebec. So basically describe the access to data for clinical and administrative data at the MUHC that is collected to all information systems. So basically at the hospital, a patient arrives to have a service. Is going to take care of the emergency at the hospital in any service that he can get at the hospital, all the network. And once that he receives a service, we, as the administrative people and the clinical based people, they collect some information and they put it in specific systems. So we call that, it's a transactional system. So we put their information. And the hospital, because they have a lot of processes, a lot of departments, a lot of people working there, they use several kind of systems that they collect data. Not all the data is stored in the data warehouse, but if you want a summary or specific sources are connected to a very structure, we call data lake or data warehouse, that have a specific structure that we group a lot of data there. Why? Because once that we want to retrieve or we want to extract some data, it's easy to go to this place to extract the data. So it's a more easy to access organization of the data. That's why we focus in a data warehouse. So today, maybe this is not actualized the data, it's from 1 year ago, but have more than 4.8 million of patients. It's more of the population of Quebec because we have historical data. So we have too many years ago data, 5.5 million on episodes, 385 tables, more than 6,000 tables columns, more than 400 million rows, 7.5 billion facts. Facts we call data points. So it's a data specific data. Here is also maybe all more than 1 year ago, but this is mainly the distribution that probably today is going to be very similar. So we have laboratory is almost all the data stored there. And we have also information of episode, operating room, imaging, emergency, and also ADT, and all the different sources listed in the right. So basically, this is how the raw data to the data warehouse mainly structure. So in the left, we have different source systems that we have we call ETL process. that try to grab the information and try to organize it to put it in a specific database in the data warehouse. And then we have two different ways to access the data: delivery platform, also a cohort explorer. This is not implemented, so it's only if you want, it's more like all the data warehouse structure is an Oracle, and to access the data is an SQL program to make queries extraction to the database. And the different option that we can get to extract the data is to performance, quality, improvements, and research. So basically, that's the four main objectives to use the data. And today we're gonna focus more in only research, okay? Any question at the moment for this? Yes. So if I understand correctly, the question is what is around the percentage between these two kind of groups, the performance quality improvement group and the research group. And someone here is asking, what is the percentage of collection of this kind of data? And I just want to say that the purpose is not collection for this. The data is not being collected for that. The data is being collected because the patient arrived to the hospital and the data is stored at the hospital. So it's independent of the future purpose that this data may be used. But if you ask the different extraction of the data and we split it in two different groups, I don't know the difference. I know more. I'm gonna show stats of the research, how many extraction we did this year and the last 4 years, but I don't know numbers for the performance, quality, and improvement to give you right now. So I cannot that comparison. Sorry, there's any other question at the moment? Yes.
So this that you showed on the screen here, how long did it take to build? Who built it? And how much did it cost?
Okay. I can say that I started to work in this project since January this year. Getting deep into the project, I don't know the answers to this question. I know that it's functional since 2019, and it was built a few years before, take a few years. I don't know exactly how many. I know that the leading project of the data warehouse was and it's continued being Dr. Backridge, that through a grant and more for research side built and helped to build this data warehouse. And I cannot answer the budget that they have been used. I don't know the answer.
Okay, yes, I have more of a clarification because I asked my colleague about this, but I know I'm not the only one who's confused about this, but maybe could you describe like what exactly is the distinction between a data lake and a data warehouse? Because we hear these terms thrown around a lot, and it's sort of unclear what is the dividing line.
So in the Zoom is fine, no? So I don't have to explain to the Zoom. I use both terms as equal. For me, I use it as equal. I don't make the distinction. Maybe there's a very specific distinction. If someone here can illuminate, please speak. For me, I use it in a very similar way. I don't make the distinction. Basically, is data lake came from a lake of data, and data warehouse is in the house. So it's a very similar term. So it's everything together in a lake or everything together in a house. For me, it's the same. So
for me,
I'm gonna speak about now the structure of the data warehouse. So basically, as a definition, it's a collection of data, let's say together, and it's patient-centered, linked within an episode of care at the MUHC. So basically, a patient is a person who we have identifiers. So we identify a specific person, and then we have episode of care. So maybe an episode of care is a hospitalization. So the patient arrived for a few days at the hospital, and everything is wrapped under an episode of care. And an episode have a number to identify that specific episode. Could be also an emergency episode, where they also have an identifier to identify that particular episode. And as a characteristic, every episode should have a beginning and an end. So all the episodes have a beginning date and an end date, except for the maybe an outpatient clinic, someone have a visit. So that is very tricky where to put the end. because the beginning is very clear. The patient arrived to the same place that the doctor is to have the visit. But the end is very tricky to establish. But normally I can define that an episode has a beginning and an end all the time. So the data warehouse is a collection of data from different sites. So MCH, RVH, M and H, the Lachine, the Neuro, and different hospitals that we centralize the data in the data warehouse. So the different system that we use is 18 different sources, these transactional systems, and everything is updated every 24 hours. So every 24 hours, we have an update and we collect the data from the day before. These have a limitation if you want. So if someone wants to create an online dashboard, we cannot give that information at the moment all the time, because this data lake is collected every 24 hours. So as a limitation, we cannot provide an online dashboard. Yes, for the day before, but not from now. Data is extracted from our, let's say that, sorry, established process for research data access. So we already have a process to access the data. And we have a full team of analysts. This is two functional analysis, more functional analysis, to manage the request of the data, and one person dedicated to make the extraction for research. So someone making the query to the database, to do the extraction, to give to the research. At the moment, any other question? No, it's fine. So basically, this is the structure inside of the data warehouse. Basically, all the around is the different sources, and in the middle is a patient center and based in episodes. A few words about the terminology. Terminology for me is super important to define, and we all agree, at least, that we are using those kind of terminology, because if someone as a researcher is asking data inside of the data warehouse, they should know how the data is stored in terminology meaning. So for diagnosis, I split here in the left the different groups of concepts that they use specific terminology. So we have diagnosis, procedure, drugs, labs, and image. So for diagnosis, the data warehouse and also the MUHC is using ACD9, and they switched to ACD10, I think a few years ago. I don't remember exactly when, at least 2-3 years, they changed to ACD10. For procedures, we're using CCI. That is here in the left at the bottom is a Canadian classification of health interventions. That is a standard here for Canada. And also for drugs, we use HFS and also DINS. We use these two kind of terminologies. If you want, DINS is super specific to a specific drug, and the other terminology, sometimes they group together a few medications, so it's more specific than DINS. Yes, sorry. Okay, so someone in the chat is asking if the data warehouse regroup a huge amount of non-structured information, video, audio, social network data. This is not the case of the data warehouse structure. So I don't understand if this is a clarification or a question. If it's a question, I can answer that all the information at the data warehouse is hospital information, and it's not coming from other sources of data. And it's a collection of structured and non-structured data. So we have non-structured, I am speaking about free text data. Okay, so for example, a report, someone read an image and they make a report. And this report is a free text. This, we call it non-structured data, is a free text. So this free text is also in the data warehouse. So I don't know if I answered the question. We have non-structured and structured data. So for lab concepts, we use local terminology, and it is not the standard. And it's a local created terminology. So to define each of the orders of the results is a local terminology. For image, we use DICOM. DICOM is a well-spread terminology for image, and is, I will say, pretty easy to be used in a hospital. And basically came more from the technological side of the machine doing the image, and it's very easy to integrate. So we use these terminologies. For that concept, I use a local terminology. I put in the right an example of a standard terminology. It's LOINC. LOINC is the most spread terminology used for labs. We are currently not using LOINC. I know that several institutions in Quebec, yes, they use LOINC, but not the MUHC. Have any question about terminology that the MUHC is using? No, it's fine. Yeah. So I put this slide because it's very, there's a lot of communication issue between the person making the request of data and the person making the extraction of data. So agreeing that we share this data is like give to all of us online dictionaries to search for specific data. For example, if I'm working in a specific disease, I am gonna group all the diseases, I group them together using ICD-10 codes. And if I give those codes to the person doing the extraction, it's gonna be way easier. So that's why I put these slides here.
I'm assuming you're using existing mapping of the internal terminology to the standard terminology. Is extraction happening from standard terminology, or is that how is that handled? So if I were to look for a specific diagnostic concept, would I have to ask you about it using SNOMED, or would that be the well, I mean, that's a bad example, I guess, but.
Okay, so basically how the terminology works, here on the right, I just put example of standard terminology. ACD9, ACD10, there are standards, also SNOMED. We are not using SNOMED, MUHC is not using SNOMED, there is a different terminology. If you want to ask data as a researcher, specific data for diagnosis, you have to be using ACD10 if you want to do a request, for example, for a specific groups of disease. And you can list the ACD-10 codes. I'm not gonna provide you that because it's a free dictionary available for all. So you can Google or use some tools to know what is the terms used by this standard terminology. And if you provide to any person making the request, they are going to be able to make the extraction properly to extract specific terms. Yes, I don't know if I answered your question.
I think so. I thought I understood the two sides as you are translating your internal terminology
it's not
into
a translation.
standard.
No, it's not a mapping. It's not a translation. It's just an example of the data warehouse terminology and some other standard terminology.
Got it. Thanks.
Yeah, it's not a mapping. Yeah. So since I arrived in January, we already have a document, actually a few documents describing the data warehouse variables. The most important, I will say, that is the data dictionary. That is a list of sources, domain, source system, data type, update frequency, since when the data is there, hospital and year of data capture. And they also have a patient flow diagram of the hospital and also the emergency medicine. So we can understand where in the flow of the patient the data is collected. So to understand the hospital flow and how we collect the data. And list of variables organized by source is around 165 variables per table. And we have all the sources. And it's a version 1.1, it's a 2019 and it's in French. And since this year, we start to work and we already finished and it's already published for all the people at the MUHC. It's a data summary for research. So basically in this communication issue between the researchers and the people working in the database and doing the extraction, it's very hard to communicate and takes time, go back and forward communication. So we try to create a document to make a summary of the data inside the data warehouse so we can provide to anyone, so anyone can read what variables is inside to have an idea. So the question and the request is gonna be easier. So in the data summary for research, we list all variables organized by source because the data warehouse is organized by source, that's why. We have the ADT, bloc opératoire, cancer, DRG, ACU, ED, accident report, images. When I say images, the data warehouse is not hosting the real image. And I don't know how it's here, probably it's gonna be something similar. It's information related to the image, but not the image itself. it have a different hardware to store image. Is way more heavy and it's more complex. That's why the data warehouse is, if you want a collection of data that we decide to put, we put information related to the image, but not the image itself. Patient index, infection, lab, medical, blood bank, and other services. It's a professional services. And it's a version 1.1, is from this year, and it's available online through the Research Institute portal.
Is this list available online, like the data source summary for research? Is it something available online? We can.
Now it's available online in the Research Institute portal for people working at the Research Institute, because it's those people who have to make a request. Okay. So it's available for the people working at the Research Institute.
Okay, cool.
Okay, I'm gonna explain later how to access or how to do a request and who have the privilege to make a request. So basically, I'm not going to describe all the variables. Just I listed here in the presentation just to have an idea. But patient identifiers, demographics is the main source to identify someone, and it's all the variables that can identify a person. So, for example, the data warehouse have a specific unique patient ID that is internal and local use at the data warehouse group. First name, last name, father's last name, mother name. I'm not gonna name all of them, but sex, RAMQ, number, MRN, address, postal code, and other identifiers to a particular person. We also have episode information. We have data warehouse identifiers, a global episode ID, dossier ID, patient unique ID. We have episode type, emergency, inpatient, day surgery, episode start date, end date, episode duration in days, episode patient age, and information related directly of the episodes. Then administration, discharge transfer. This is the ADT. This is a system, I would say, is one of the most used system at the hospital. All related to admission, discharge, and transfer. If you want, is wrapped in this system. So we have the information about the admission, about the discharge, about the transfer, and all the most important variables inside of these three categories. Also, we have what it was a few years ago, archives or Medeco. It's for inpatient and day surgery only. And this group is very good because they make a validation and they can improve the data that is inside. So, for example, if they need to make a mapping or put, for example, a DRG severity code, they are in charge of doing it. And they manage intervention, principal intervention, secondary intervention using CCI code, and the description, date, physician service for diagnosis, principal, secondary, pre-existing diagnosis using ACD-10 codes, DRG, severity, mortality. Basically, the DRG is a number that is going to say what is the severity and mortality of this patient. So if this is more for, historically for more billing purposes. So how to pay a hospital and all that. Some hospital, I don't think it's being used here for billing, but other hospital, for example, in US, yes, they correct me, yes. It's more for billing. So let's say a more complex patient is in another category for billing. For services, physician, specialty, date, and duration, and consultation, domain, physician, and date. So basically that's archive. I'm not going to go to, yes. Okay, so so they're asking in the chat, do clinical teams member enter the raw data themselves, or is it translated by the extraction team? The extraction team is not in charge of changing any data, or is supposed to not be changing any particular data point. So they make the extraction. The translated part, if you want, archives have the power to correct and validate the information, the raw data entered by the clinicians. So if you want, it's an extra validation after the patient leave the hospital, archives in charge of arranging the terminology used. So for example, the DRG code is not entered by the clinician, it's entered by a group of people specialized to classify that particular. I don't know if I answered the question. But, I'm not going to describe all the sources of the data warehouse. The idea is to have this one also because I consider it important. It's drug information. So for drug information, basically here in the left, we see the hospital cycle of the medication. We have prescription, transcription validation, dispensation, administration, and monitoring. Basically, that's the hospital, not the pharmacist medication cycle, just the hospital. So for that information, we collect information for the prescription and also for the dispensation. And this is the variables that I put as a summary of the variables that in each of these categories. This is other sources. I'm not going to describe all of them, but basically we have emergency, ACU, surgery, Quebec Cancer Registry, infection control, laboratory, general lab, microbiology, pathology, medical imaging for the request information and also for the exam details, blood bank, patient, product, and the transfusion. So before requesting the data, the principal investigator must have research institute privilege or an appointment at the research institute to request the data. That is how we understand now the legislation to share the data only with people associated with the research institute. That's why if someone outside of the organization want to access the data, how to collaborate with local researchers to make a request. Actually, first make a protocol, make all the approvals before, and then make the request. The research ethic board approval for all requests except for aggregate data. Aggregate data is impossible to identify someone, so that's why the research ethical board approval is not needed. For example, how many patients the emergency department saw last year? So it's just a number. It's 5,000. I don't more, but it's just a number to identify a group of people. So we cannot identify never someone. So that's why the approval is not needed. And patient consent or DPS only if it's nominal data. So it's defined as information with direct identifiers. Name, last name, rank Q, all the direct identifiers would not be there if the researcher don't provide the patient consent or the DPS. The data warehouse must ensure that the data available is there for the research project. And here is where the communication should be done. So the researcher already have a protocol approved and how to send a request to the data warehouse people. And data warehouse people have to say, yes, we have it. No, we don't have it. If the researcher is not sure if the data is there. The MUHC data warehouse analyst, basically we offer to give a consultation. So if someone inside of the research institute want to make a consultation to the group, we plan a meeting so they can discuss about what is the data available if other sources of knowing what is data inside is not enough. This is the request status summary. I just make it this morning. So basically this is historical data and this is from this year. So historical data, we have evaluated non-treated 478, treated 58, on hold 117, working on 12. This is the historical data. And total 675, and this is already 4 years of being there. And from this year, 64 evaluated not treated requests, treated 13, on hold 2, working on 3, a total of 86. So data warehouse next steps, what we're doing is working this data governance framework to try to make a document specifying how is the relationship between the MUHC and the research institute and make an umbrella of how the procedures should be put in place. And also we are recruiting personnel, software engineers is already working in our group, and a new data scientist that is gonna join. And we are working in a new structure of the data warehouse, starting slowly to have real-time database structure. So information, basically at the beginning working with the ADT trying to make it available as we have. So if someone arrived to the hospital, we can know the information through the data warehouse after he arrived or after someone put the information in the system and almost online. So basically we're doing that, working in that line. And also in the data access process, we are trying to improve and make a new request workflow. The current process have some communication issues and some, it's taking too much time to get the data from the from the request initiation. So we're trying to improve this time. And also we're trying to implement Shira software manager for the request that we consider that is an improvement in the software that we are using right now to do the request. Okay, so in this moment, I finished with the data warehouse. So is any question about this is the moment, and then we'll speak about synthetic data. Yes.
And just if a researcher has an idea but doesn't know if the project is feasible, can contact you to like have an idea before going through the ethic process and all the other approval? Can they contact you to see, for example, how many subjects?
So the request we divided in actually in the new software that we're trying to configure it. We're going to divide it in 4. One is consultation. So the researcher have to have only access to the portal to make a request for consultation. They don't need nothing, just make a consultation. So if they don't know what is the data inside, they can maybe know, or they have a meeting with someone inside of the data warehouse team. And the other 3 is different kind of data requests. One is aggregate data, the other one is non-identified data, and the other one is identified data. So we classify the request based on this, let's say, privacy, security levels, because the requirements to apply for data, they are different. Yeah, there's any other question? Yeah.
Do you have any formal policies regarding differential privacy for your aggregate data access?
It's a good question. Not that I remember. If you ask me if there's any policy or process how to follow if someone requests aggregate data, not to my knowledge. No.
Thanks.
The idea is to have first a document approved by the hospital saying this is a framework of all the data for research, and under that establish the process to be more detailed.
I have a question about the requests. So you said there are different levels of requests for aggregate data and so on. You have, it sounds like consistent terminology within the warehouse. So I have 2 questions. One is, if my interest is in exploring your data without making a formal request about individual data, you showed a cohort builder.
Why you want to explore the data?
I don't want to explore individual data. What I try to get a sense of is what kind of population I could make a request about before I make a request.
Population. Right? If you want to know a specific question to know more about the population that you're intrigued, you can make a aggregate request. So how many patients with X do we have, or how many X to know a big idea.
So I guess exactly that's my question.
The data warehouse is not something that we provide access to someone just to understand.
I think that answers my question. So my question is this an asynchronous workflow where I say, hey, how many people do you have with Parkinson and this and this and this, and then you come back and then it goes back and forth?
Yeah. Okay. The request is an asynchronic consultation. So you make a request, create a ticket, and someone is going to work in that ticket to give you the answer after, not at the moment.
And that cohort builder you were referring to, that is for internal purposes only in that context?
The what, sorry?
I think in one of your slides you had a cohort.
Yeah, I'm going to speak now about synthetic data. That is a different things that we're using a software to create a cohort.
Got it. Thank you very much.
The software that they're using to extract the data is not a cohort creations dedicated system. It's more like a database to make queries, to make a consultation to the database. not in a form of a cohort. But you can define a cohort in that structure. But is there any other question?
So if a researcher wanted to see what are the variables, like the dictionary is available, right? He doesn't need to have an appointment with you, right?
Now the process is this data of the MUHC is available through the Research Institute. So we provide the dictionaries to people working at the Research Institute. If someone external wants to have access, how to be in collaboration with someone inside the Research Institute. That is based on current legislation that is only shared through the Research Institute for research purposes.
Okay.
Okay. These slides show a lot of variables, also very specific. It's going to be online. It doesn't provide any private information, so it's fine.
Just another question.
Yes.
So once a project is approved and data is ready, how do you transfer data to the researcher? How do the researcher have access to the data?
Okay, we use a specific software in the cloud, very safe to share this data. And the researcher have to create an account and they can transfer the data. Okay. Sorry, I don't remember by heart the software. I can let you know in a few seconds. Or after the presentation, I can check. So I'm going to speak about synthetic data now. Synthetic data, so basically, sorry, one before. So do we have another hospital database available for the Research Institute, MUHC, and McGill? So now we're working, the Research Institute and the CLIP in partnership with the Faculty of Medicine and Health Science, the Department of Surgery and Medicine at McGill University have signed an agreement with MDClone, that is a private company, to foster innovation and collaboration in health science through the use of synthetic data for over 3 million adults and pediatric patients from Israel for research purposes, okay, using synthetic data. So first I want to define what is synthetic data, so we all are on the same page. So synthetic data is a non-reversible artificial created data replicating the real world raw data, statistical characteristics. So basically it's a copy of the real data, and all the data points are slightly changed. So it's not the same data point, they're slightly changed, but they keep the same statistical characteristic in the groups of the data set. So we can make analysis and we can make testing using this data that it doesn't require protocol approval, rev approval, or other policies in place to ensure privacy. So using discrete and non-discrete variables of interest, synthetic data does not contain identifiable information because it uses a statistical approach to create a brand new data set. For this particular company, I don't know exactly how the data set is created, so I cannot share that with you because I don't know. I have an idea of what they are doing to build something similar to the real data, but I don't know the algorithm that they're using to slightly change. So while an individual with anonymized or de-identified data can be identified, so this is the thing. We have a data set that could be with identifiers, without identifiers, or let's say synthetic. So with identifiers, we have direct, we can grab only one or maybe two identifiers and we know the data belong to whom. And at the possibility, we extract all the identifiers and we have real clinical data or administrative data of those patients, the real one. If I have access to this database that is anonymized, I could have another data source and merge them together and say this data belongs to this one, because if I mix together 3, 4, 5 non-identified variables, is so unique that I can say this belongs to one person, okay? So the synthetic data avoid this. So it doesn't matter if I group all the information, it's fake information, so I cannot identify no one never. So basically this is the relationship between privacy and data utility. So basically, as more private, normally the utility of the data decrease because I change the data to increase the privacy. So the utility is gonna go down. So the idea is to be in the right top point where the maximum privacy and the maximum utility is kept. That's the idea. So speaking about this particular software, this MD clone, they have two software. One is a query tool, and the other one is a visualization tool. So the visualization tool, I can put in an Excel file, and I make some analysis, graphs, and analyze the data. And another tool that they have is a query tool. So it's if you want, it's a mix between what the researcher need and the people making the query. So it's a very easy way to make a queries to a database. At the end, is that. And it's as a researcher perspective. So the researcher have to create a cohort. The SQL software engineer, they don't have to create a cohort. They have to create a query. So if you want this software is mixing these two. And the user is doing a query in a very research way, I would say. So the benefit, we can make retrospective research studies, explore data independent of the Rev approval, access data at the moment, explore data dynamically, maintain patient privacy, share the data with worldwide, and it's ideal for artificial intelligence testing. So we can start to feed algorithms using machine learning with these fake data sets, but very similar to reality. So as a limitation, it's not useful for prospective studies, a minimum of 200 patients, because if they argue this, if you make a query of 2 persons, you can identify those. So have a minimum cohort population to make a query that is 200. Some information is not available using synthetic data, for example, images. The same data warehouse, they don't provide image. I say it's not the same because if you provide the image is so specific to a person that you can recognize someone. You cannot slightly change the image. So that's why they don't have image neither. Categorical variables are censored in a high percentage, and the more specific, the more censored. So basically how it works, of my understanding of how it works, you have two kind of variables. You have numerical variables and you have categorical variables. For the numerical variables, yes, we can create an algorithm to create slightly similar to the reality. For example, temperature 37.1, we slightly change this to 37.2, and we keep the same mean of all the temperature in the group. So that it could be changed. But for a categorical variable saying this person is Canadian, we cannot slightly change Canadian. So what we do, or what the company does is they can censor the data. So for the same cohort, they change the percentage of censoring of data. So for example, if you ask a query of 25 categorical variables, the percentage of censoring in each of them, they're gonna be high. But if you ask just 2 categorical variables, the censor is gonna be lower. So they play with this percentage of censoring the data for categorical variables, so they can keep privacy enough. Another limitation, yes. Sorry? Okay, so multiple repetitive events are not available. So if in the query, we cannot ask, give me all the medication this patient received in their life. So repetitive events is so specific that could not be asked, but there's a tricky way to do it. You can make a consultation asking, give me the first medication, give me the second one, and you can grab a few, but not all the events. And how it works basically is in the left, we have, sorry, I say we, but it's not, I don't work for this company, but reference event at the left, 2 additional inclusion, time-related events, demographic, finalize the cohort. So how it works, this basically is connected to the data, to the hospital database. And in the first one, we define a reference event. Say this event is gonna be all the patients between 18 and 120 years old that have this diagnosis and this diagnosis, that have a hospitalization. And we define the event. This is going to define the population of all the cohort. And it's gonna give a number here at the bottom, 25,000. It's gonna give the number of the reference event. Then we define additional inclusion. If there is any additional inclusion, we define it. And also the time-related event. what information of this population I need. And I have to define here in the left, for example, triage information, past Charleston comorbidity index, and all the variables that I want of that population. And then demographics is a checkbox specifying what information in demographics I need of the population. And then finalize the cohort and output is gonna show a summary also with the censoring rate to know if it's 90% censor, just 0.2 censor rate. And when someone click create synthetic cohort, at this moment, it's touching real data. But when someone tries to extract, generate a synthetic cohort, synthetic data set that you can download. So it's very straightforward to create a cohort using that. So basically this came to solve one issue, the communication between the researchers and the people doing the query to the extraction to try to grab information from different places. And if you want, it should be centralized, and then it's gonna be easy to use for a researcher in this case. Locally at their institution, I think in Israel, they're using for real data. So researchers that have the privilege to access the data, they can go directly to the software and create the data set of real data. But here we have it available only for synthetic. So basically there's only a few minutes, so I'm not gonna speak too much about this. So basically these two ongoing projects, one to synthetic data reproduce brain tumor primary research data. So it's trying to validate that using synthetic data is similar to using real one. And the other one is a personal project that I'm working in, hospital admission prediction for elderly at ED visits. So basically we are trying to predict the patient that are going to finish at the hospital once that they arrive to the emergency department. So the probability is how much? Actually, it's a yes, no, and we have to reach a good accuracy of the prediction. I'm gonna skip this. So basically, this is a comparison between the synthetic data and the real one, that a project that is trying to be published right now. So basically, it's how the level of albumina is related to survival in glioblastoma patients after the surgery. So here we see that they are grouped in 3 levels of albuminemia. So for example, if you have a high level of albumina, let's say that you are in good shape, so the survival is gonna be higher. If the albumina go down, probably means that you lose weight and you are very bad, and the probability of survival is low. So using left real data already published, and in the right, using this kind of synthetic data, that the distribution is very similar. This one is an artificial intelligence amazing project. So basically, it's an elderly patient, ED visit and hospitalization. I'm going to try to pass fast. So basically, we have 2 objectives. One is to predict likelihood of hospitalization from ED using machine learning, and the other one to predict the likelihood of an ED revisit and hospitalization within 24 hours of the ED visit. So basically, we don't care if the patient go out of the ED and came back. If the patient get hospitalized in the 48 hours, is good to know, is good to predict. So that's the difference between both. One is directly from the ED, and the other one is 2 days. So these steps, this is strategy that I would say any artificial intelligence project could follow. That is a literature review, create the data set, define the variables, create the synthetic data set in the case of using this database, data pre-processing, filter selection, model training, model evaluation, optimization, validation, and then, if needed, deployment and monitoring. So basically, we're in this project, we already finished the green, we're working in the middle one, and we are not there in the blue ones. So basically, we make a literature review. There's a lot of articles speaking about the same, trying to predict hospitalization of ED visits. And we create a data set with some limitation that are very similar of the limitation that I already mentioned. And there's the index, the triage emergency severity index, it was not reliable. So we have to remove it. And then other things that they have limitations. And we create a synthetic data set of 25,000. This could be done in 1 hour, but there's a lot of back and forward between I create a data set, I see the Excel, I would like to change something, I go back again, and this forward, but I can do it myself. So 25,000 ED early patient visits, and we remove at the beginning. We decide we're gonna work with clean data, and we remove sensor and missing values. So we remove almost the half of the cohort, and 13,000. It was a good number to work on. So we decided to move with that to clean the variables. First, we define the variables in the literature, and then we select what is the variables that we're going to start with, because we cannot start with all of them because it's time consuming cleaning the data. So we work with the first that we consider most important, and we clean the data, and basically we feed the program. Some pre-processing. This is the data baseline characteristic, all the variables and the mean of each variable, and hospitalization and discharge. And we were lucky because we have a distribution of half and half between hospitalization and non-hospitalization. So for the prediction model, I would say that is better. So we run two models, random forest and gradient boosting. The numbers, the accuracy that we reach, only using the variables that we initially selected, it was not enough to reach, let's say, 0.85 accuracy of the prediction. So it was not very good compared with other articles. But the idea is to try to improve the variables cleaning to fit better the model. But it's not half and half, it's 0.65%. So it's better to have it than don't have it. Yes, 1 minute, okay. So next step, add more variables to dataset, feature selection, model training and selection that we're trying to do. And to access MD clone, we have first the people that have the privilege to access here based on the agreement between the Research Institute and the CLIP is any researcher associated with the Research Institute or McGill University as a whole, because the university also is in this agreement. So if you have any position at the McGill University, you can also have access to this data set. So what do you need to provide me to request your access is list here all the requirements, name, last name, McGill ID number, or Research Institute or MUHC, phone number. We ask for the public IP, just a parenthesis in this. All the hospitals that I know, they block connection from outside of their country. So I don't know if you try to access hospital data here from outside of Canada. Normally they're recognized through the IP that you're outside of Canada, so they block it. It's a security measure. Israel is doing the same. So any connection to the database is blocked by the IP that is outside of Israel. So that's why we ask, what is the IP that you're gonna be using? We send it there, they approve it, and then you can access. To complete an online video training that is 2 hours and sign a confidentiality agreement. Basically, there's two main points. Basically, you cannot sell or give to third parties even if it's synthetic data. And also, if you want to publish something using this data, you have to send a copy of the article. In 1 week is approved or comment, and then you can publish. So I think I finished.
All right. Well, thank you so much for the great presentation. I'm sure there's been a lot of questions already. I'm sure, and maybe what I like to do is if Pierre, we have the chance to have Pierre Lemay with us today, who runs the Perfocentre here. So maybe if we just briefly a bit make some points about how things are similar or different with the Perfocentre here, which yeah, that's right.
Hi, thank you, Dr. Marquez. Hello, everyone. So I'm Pierre Lemay. I'm the Associate Director of Performance and Data Valorization here at the CS of West Island. So the Douglas. Just a quick comment. So yeah, we have basically the same organization of infrastructure data that you show, Dr. Marquez. So we have the data source, the data warehouse, data lake, and the workflow is similar with extract, transform, load. So we're basically in the same mindset of this the MUHC. But we have a lot more of different type of data, because we have all the community-based data from the CLSA, the CHSLD, the Bacha Youth Center, and probably the Chrome, the Chrome Center, West Island Readaptation Center. So we have a lot more of a different type of data. One of the other difference, maybe you talked that you were starting to build some data in real time. Here we already have some of our projects that are in real times. Maybe you've see in the media the information or on LinkedIn that we started at the Lakeshore Command Center, a data controlling command center. With real data, to see the process and the workflow of the organization in live in the control room at Lakeshore, and we will happy to say that we will open one here at the Douglas in a couple of days. It will be announced very shortly. So we're already coming with real-time information here at Douglas. So basically, maybe one other time I can explain to all the research community how to have access, but it's very similar at the MUHC.
Just a follow-up comment.
Yeah.
The MUHC also have project ongoing with real data. I think the command center you mentioned, I don't know if it's the same emergency command center, that they are also working with real data. But just to clarify, it's not through the data warehouse. Just in the meantime, just to answer, I remember the software. Nextcloud is the software that they're using to share the data.
Thank you. Yeah, so I'm just wondering why the choice was made to go with MD clone for this software. Because if I understand correctly, the algorithm or the actual method by which this data is generated is completely unknown.
Mm-hmm.
So wouldn't that kind of limit the applicability in a paper? For example, if you say your data is generated from, I don't know, we don't know where the data came from.
Okay, first, I agree with you that not knowing is worth that knowing. It will be better if we know that, but the understanding, because it's a private company, if they give you how to do it, you could do reverse to change it to the original somehow. So here I say no, but that's my understanding that's why they told us that they don't share how to do it. About the decision, it's not a decision that I make. If one is an agreement of a professor working at the CLIP and working in collaboration with the research institute that have an agreement, and we take this opportunity to provide this access because this agreement is already signed. It's not something from the MUHC or government decision to have an agreement.
Great. Okay, so I guess we will end the presentation and the discussion for now. So thank you again, Santiago, for a great presentation. A lot of questions. Clearly, there's a lot of interest with your work. So thank you again for taking the time to come here today.